Start recording.
The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the Chronic Disease Preventative Care and Management Project Team webinar. I see we have several, we have many of the registrants already on the line. So without hesitation, we will get right to it. This is Colleen Florio at Adirondack Health Institute. For today's webinar, I'll give a brief overview of the project, especially some issues that are unique to this project because it is a Domain 4 project. We will then go into the project requirements and work planning, as well as speed and scale, and finally, project budget. So this work group is addressing Project 4B2, increasing access to high-quality chronic disease preventative care and management in both clinical and community settings. The objective is to increase the number of New Yorkers who receive evidence-based preventative care and management for chronic diseases. I can say that some of the feedback we got from the plan that we submitted back in December is that they would like to see a little more emphasis on community-based prevention and management activities. They felt our plan was heavily clinical in nature. If you would like to see the actual plan that was submitted in December, it's part of the application, and that application is posted on our website. The link is shown on this slide. So a few things that are unique to this project because it's in Domain 4. I know many of you on the call take part in other project teams and want to make sure that you're aware of how this project differs from those in Domains 2 and 3. So Domain 4 projects, the Department of Health has not predefined for us specific milestones or process measures. The outcome metrics for Domain 4 are Behavioral Risk Factor Survey System, BRFSS metrics, and those metrics are paid for reporting for all years. So this is, in terms of the measurement that's been predefined, it's very different from Domains 2 and 3. The document that is used by teams addressing Domains 2 and 3, called Project Requirements, Milestones, and Metrics, it does not contain any information on Domain 4 projects. So if you're on other project teams and you're looking in that document, looking for some detail on this project, it's not in there. What they did ask was that in our December application was that we submit some draft milestones and metrics. So we were able to draft some of those that were specific to our project. There is no speed and scale requirement for this particular project. So Domain 4 projects, by the nature of being in Domain 4, they're considered population-wide projects that the implementation of the project is required to address the PPS target population as a whole. So the project requirements, I've listed them on this slide and the following slide. Really, when I look at the requirements, I can see why there was a lot of emphasis, more clinical than community-based kind of emphasis in our work plan, but in our project plan that was submitted in December. But I just wanted you to have a reference here for what those requirements are. Some of the requirements are ones that would be really handled, in part at least, by the governance of the PPS. So when it comes to working on requirement 1, such as establishing or enhancing reimbursement methodologies, that aspect of the project I would expect would be addressed through the PPS, through the governance. Other sections of the project, such as adopting and using certified electronic health records, especially those with clinical decision supports and registry functionality. Other requirements such as that IT one are part of the planning of the IT work group. So I've kind of put in italics the requirements that I think are more relevant to the work of this particular project team. So making sure that the clinical preventive services that the recommended services are being offered, and that patients are connected to community-based resources, that patients are getting reminders for that preventive and follow-up care, and that there are community-based resources available to support disease self-management. A few more project requirements we'll show here on your next slide. When it comes to adopting medical home or team-based care models, given that the PPS is pursuing patient-centered medical home status through Project 2A2, we know that as a network, we're moving forward in that direction. We would want to make sure that our clinical quality group, which would be a subcommittee of the board or of the network it hasn't been established yet, but the body that oversees clinical activity and performance would be relying on input from this group to make sure that there's a process in place for clinicians to be getting feedback around the clinical benchmarks, and that there's some incentive there for quality improvement. So at this point, what the PPS needs to do for this particular project, again, no speed and scale, but we do need to develop a work plan. And we have really are in a good place to start that work plan, because many of you, when you took part in the templates that were submitted last December, put in quite a few steps and activities that would build towards that work plan. What we really need to do now is just tie in those steps, maybe add some others, and tie those steps directly to each of the project requirements. So basically, the work plan template will be a list of all the project requirements, and there will be a spot for you to fill in the steps that are needed to meet each requirement, as well as a projected target date by which you believe those requirements can be met. At this point in time, it's really something that I wanted to address during the discussion as to how you want to proceed as a group. Our goal is ultimately to have one high-level work plan that's common across the entire PPS network. So ultimately, that's what we have to do. That's what we need to get to. We need to get to a common set of core steps that everybody is reporting and tracking on. But in addition, you may have a more detailed kind of local, specific set of steps that are part of your local work plan. Our options are that you could go ahead in your regional teams and do an individual work plan that's for the implementation of the project in your region, and then we can take all of those and look for common elements and common structure and try to develop that network-wide work plan from them. Or as a team of people who are on the phone today, and maybe some others who couldn't make it but will be joining the project team, or as a team, you could start right at that top level. You could look at the requirements, and as a group, work on developing the steps that feed into those requirements. So I just put that out there for you to think about for a few minutes, and I'd like to hear your thoughts on that as we move towards the Q&A near the end. We will need a work plan, whichever it is, that single high-level work plan from this team as a whole, or those individual ones from each area. We will need those by April 22nd. So those work plans are, excuse me, those work plans are not part of the April 1st submission that the PPS is required to submit to DOH. So many of you are familiar with the April 1st submission date, and we are moving towards that date. but we do not need to include the work plan in that submission. Okay, so the PPS at this point in time is very much in need of a project champion. We've identified a need for a project champion for our PPS projects. We're looking really for someone to serve in a leadership capacity to head up the project across the entire network. We're developing a scope of work, and the projected time commitment is approximately 1 day per week. The MOA would be valued at approximately $20,000 annually. This person would be really the key leader for this project. So that person would we already have and would continue to develop subject matter expertise in this area, and would provide network-wide project leadership. So this would be the person who really knows the ins and outs of what we're trying to achieve with this project, and can be the voice and face of this project to the various regional teams and partners. They would oversee the project and monitor progress, participate in statewide learning collaboratives, set meeting agendas, and facilitate meetings with the support of the AHI project manager. So we are recruiting for project managers at this point in time. We do have a project manager in place for the behavioral health related projects, and we're recruiting additional project managers. So I don't know yet who the project manager would be for this team, but the project champion would be very much supported by a project manager who would handle all of the meeting planning and team-wide communications. They would be using our tools to produce reports on project status. They would be putting together any materials that the team might need to do their implementations. They'd be performing the routine kind of documentation in our project management tool, which is called the DISRP Tracker. So lots of support from a project manager. Preferably, the project manager that is recruited will have some background in this topic area, but not necessarily. So they would be more managing meeting requirements and reporting and deliverables, but we really still need that project champion to be a real leader in achieving the goals that this project sets out to achieve. So if anyone has an interest in this project champion role, I would invite you to simply email me, and we can discuss it further. Okay. Before we speak to budget, as I close up that project champion discussion, I just want to mention that given that there is not a champion or a project manager in place for the project right now, you may find it simplest to simply do the work plans within your regional teams and send those in for the April 22nd date. If there's strong interest among the group in doing a single high-level work plan now, I can facilitate those meetings, and we can get some things on the calendar and work with you to do that. But we'll be much better able to do that type of work when we have both a champion and a project manager in place. So if you want to go in that direction, again, we'll discuss it during the Q&A. But given that those two roles aren't filled, if you prefer to go just at your regional levels for the work plans now, that we'd be fine with that. So let's shift over to budget for a minute. When it comes to budgeting, some of you attended a meeting in Lake Placid a few weeks ago. Since that time, the budget template has been updated. There have been a few changes to the instructions. The updated version is available on our website. In addition, the PowerPoint that Lynn Wadley, AHI's CFO, that Lynn walked through at that Lake Placid meeting, that PowerPoint is also available on our website. If you haven't taken part in any meetings to date where budget has been discussed, I would strongly encourage you to go ahead and download that budget template. The first page of it has instructions, and to look through that PowerPoint. I think that'll give you the initial background that you need. Then in addition, this Friday, March 6th from noon to 1, there will be a project budgeting webinar. At our website, you'll see the link where you can register for that webinar. And this would be your opportunity to, review the template with Lynn and ask any questions that you might still have around budgeting. One of the questions that was asked a few weeks ago in Lake Placid about budget, I'd like to address now. That question was, when doing budgets and including staff time, be that clinical time or other staff time, it was asked, do we need to prorate that based on the amount of Medicaid patients served by that individual or by that program? And the answer to that is no. So if you're preparing a budget for a project, and in the context of doing that project, you know that you'll be impacting both Medicaid and non-Medicaid patients, you do not need to take just a proportion of the costs that are proportional to the amount of Medicaid patients served. You can put in the full costs, the full expenses, and any revenue generated as well. So again, budgeting, I'd encourage you to be on the Friday webinar if you have questions. If you do have some more questions during the Q&A today, I can attempt to answer them. I can also sum up those questions and get them over to Lynn so we can get answers to you. The budget templates are due back to AHI on March 13th. And just send them to the address you see on your screen with the subject line project budget. So the slide you have here gives you some of the key dates that we have in March. We're currently in a window of time where we can add new partners to the PPS network. There may be some organizations that haven't signed up already that would like to take part. We can add them in up until the 9th of March. We're in a process of looking at the partners that are in the network and determining if there are any gaps. Are there any partners we need to add, and anybody that we need to do outreach to. The important date for this project team and for all project teams is the project budget and template due date, which is March 13th. Again, this particular project, there is no speed and scale template. So nothing for speed and scale for this project, only the project budget template. We will then submit an implementation draft to KPMG on March 16th, and on the 1st of April, we will submit our final. So at this point, I just would like to mention that it probably seems to you that there's not a lot new or different coming from the project teams right now. And that's true. I mean, at this point in time, the network is trying to get a handle on what those overall project budget costs are going to be for the network as a whole. So they're very interested in seeing your budget templates so that they can build the network level budget. When it comes to really developing more of the details around those work plans, that's an important process, but it's not part of the April 1st. It's not part of the April 1st submission. What we are doing for the April 1st submission is there's quite a bit of that plan that has to do with the development of the governance structure, the financial model, and the health information technology evaluation and planning. So I would call it more network infrastructure is what's being developed and reported in that April 1st implementation plan, with just a few additional pieces about the projects. So not a lot new with the projects right now. That being said, we are very interested in getting both a project champion and project manager in place. So don't hesitate to get in touch with me if those are roles that, if you have interest in those. I'd like to suggest that you sign up for an account on the Mix if you haven't already. The Mix is the Medicaid Redesign Team's Innovation Exchange, and it's a site that DOH has established specifically for Medicaid redesign initiatives. It's mostly all being used for DSRIP and for PPSs right now. The website is a communication platform You can set up groups. You can join groups. It's a place where you can connect with other professionals, with other healthcare providers that are part of the same types of projects that you are, that are in other PPSs. You can share information, share resources. There's also an option for PPSs to use this to develop, to share information internally by creating their own closed kind of group. And we haven't done that yet. We're going to talk to the district support team and make sure that we understand the tool and how to implement it so that we can use it within our PPS to more effectively communicate and share information. So at this point in time, there is no AHI specific group, but I would encourage you to just go ahead and get an account so that you're ready. And the link is shown on your screen for how to go ahead and get that account. So at this point, I'd like to open it up to questions. The way to ask a question is you click on the little hand icon that you see in your toolbar there, in your menu. You click on the little hand to raise a hand, and then I'll be able to unmute you. Someone has asked that I repeat what the BRFSS stands for. It's the Behavioral Risk Factor Surveillance System. And Jody, I see that you have a question from the last webinar on palliative care, and so I think you're still on. So the question is, please clarify what is meant by a palliative care procedure at a participating site. That's the extent that I have of the information from DOH on how that is, on how actively engaged is defined for the palliative care project. I'm told that they will be releasing a manual that gives more detail on the measurement of those actively engaged criteria. Wherever possible, if they can obtain the information to determine the numbers of actively engaged from claims-based data, they will gather it from claims-based data as opposed to us having to develop our own data stream. So I know that doesn't really answer your question, but we will get more, we will be getting more information from DOH on how those numbers are going to be measured. Since the project is increasing access to palliative care programs and services in patient-centered medical homes, I'm assuming that they're basically going to be looking at, you know, the PCMH practices that are taking part in the palliative care project and looking for certain types of codes that indicate palliative that palliative care has taken place, would be my guess. And I have another question which says, are we going to get attribution numbers from the Department of Health? Yes, we expect that we will be getting final attribution numbers sometime. We're told we'll be getting final attribution in mid-March. We do have some some preliminary attribution information, and we can share that with you. We've been in the process of obtaining BAAs from all of the organizations that are part of the PPS. I've just got to get a report from our contract managers to where all the BAAs stand and see if I'm okay to release all that attribution information. Okay, seeing no more hands raised, that will end the webinar for today. Thank you, everybody.